here.
I went to bed very early last night.
All right. I think, where did Terry just go? James is out.
I've never had the surgery.
Yeah, well, I recognize people.
There he is.
Yeah.
Speak of the
I
devil.
hope you don't take that offensively.
All right, so.
No, but I do get tight.
Go ahead.
Okay, so our next presenter is Mark Larson, who is currently the director of residencies and fellowships with the Katie. Now, I had asked Mark to come in and talk to us because we have focused a lot on healthcare and how to ensure our athletes are getting adequate care. A lot of what we've heard today, it, I think, is beginning to show us that the current model, the current infrastructure leaves a lot to be desired. So knowing Mark, knowing his background, knowing what he's done while he was at Boston University, I thought he's an ideal candidate to come in and talk to us. He's a good friend of mine. He's a trusted colleague. I've done site visits with him and literally I'll be thinking something and Mark would say it, and vice versa. It was really uncanny. I don't know that, don't let that be a bad reflection on him. But Mark, welcome, and we appreciate your insight, my friend.
Thank you, Greg, and thank the committee for having me here. I'm excited to talk to you, and let me share my screen here. It's always an adventure for me. Okay, and then start the PowerPoint. There we go. Get these folks over here. Get rid of the chat. Well, again, thanks for having me here. I think Greg and Jerry are both really, really good friends, and I'm happy to be here to talk with you. I was at Boston University for quite a while. I'm a son of a college basketball coach at a small college in North Carolina. And I've been on at Division III schools and Division I schools. Had a cup of coffee down at University of South Carolina for about 10 months before I went back up to Boston University to really change the healthcare model there. So I want to talk a little bit about that and answer any questions you have. And I know we're limited time, and we got a former congressman coming in next, so we'll go as quick as we can. So Greg took care of my disclosures already. So here are the objectives. Pretty straightforward. Let's see if I can. Independent medical care and its benefits are not new. University of North Carolina moved all of their athletic trainers out of athletics after an athlete death. Probably back in the 70s. Princeton was out of athletics, and their athletic trainers were supervised and worked in student health services. Way before that, Northwestern University has just moved all of athletic health care into the medical center, which has taken over also not only all the athletic medical care, but also has taken over the student health center there. Vanderbilt has moved theirs into the Department of Orthopedics, as has Iowa, and has their athletic training educational program at Iowa in the Department of Orthopedics, and all the athletic trainers who work in athletics work for the Department of Orthopedics. And then, of course, Maryland moved all of their athletic trainers out of the athletic department after the Jordan McNair death. I was fortunate enough to help with some of that work, both as a consultant to the president with a group of other healthcare professionals, and the Walters Group, and then also on their athletic healthcare advisory board. So let's just jump right on in. So we're going to start out in the context of patient-centered care and delivery of true patient-centered care. And one of the beefs that I have, and while John Parsons is a good friend of mine, actually was in my wedding, and I think Brian Hainline's done a magnificent job. I do have a little bone to pick with them when they talk about athlete-centered care, and I think that we do our students a real disservice when we label them in any way, whether they're a drama student or an engineer. When we're talking about healthcare, it shouldn't matter what activity or what roles that they have on our campus. Healthcare should all be the same. And and in regard to athletic training, just look a little bit here, and I'm not going to read this to you and work through it, but in a traditional model, and this is healthcare in general, and the patient is really passive, care is really disease-centered. In a patient-centered model, which is what all of medicine is striving for now, is a patient-centered model. We really partner with the patient. It's quality of life centered. It's not just one activity or one role centered. And we get much more adherence. And I think we also really focus in the patient-centered model of building healthcare literacy and skills. And I would submit to you, and we'll talk about it in a couple times during this talk, that the way we run healthcare in colleges and universities right now actually retard our student athletes' ability to function in the healthcare environment they're going to after they leave. And it may be, with the cost of healthcare, the complexity of healthcare, it may be one of the biggest handicaps we have them leave our campus with. They're going to go out and very quickly have either ailing parents or a family, and they're going to have to navigate the healthcare system on their own. And that's a daunting task when you've never done it. So what are some changes to our traditional structure that we can talk about? And I think one of those actually lies within my profession, within athletic training, mine, Jerry's, and Greg's profession, and that is that athletic trainers traditionally have been working in cultures that were win-oriented and very coach-centered. And athletic trainers at many places are receiving bonuses at the end of the year if the team does really well, receiving other benefits, whether it's courtesy cars. That culture is not a healthcare culture, and it clearly is a conflict of interest. In addition to that type of culture, the athletic training clinic becomes a place where athletes hang out. And while I think we as athletic trainers say, well, they need a safe place to be. Well, I think I 100% agree with that. But it's a health clinic too. And if you have patients in there who are getting treatment for health conditions with other patients who are kind of just hanging out, then we have issues of patient privacy. We have issues of sanitation. So there's a lot of things around this culture that is difficult. And then just the culture of athletics. Certainly, the culture of athletics is really pervasive, and we put up with a whole lot on college campuses. and a whole lot of as faculty members, and I'm a longtime faculty member at several institutions. I think we think we just can't do anything about it, and I'm not sure that's true. But this is the type pressure and environment that healthcare professionals are working in when they work in an athletic department and work for an athletic department and are paid by the athletic department. And it's not just a college problem. Oh, I have a photo there of it's supposed to come up, doggone it. It was a soccer coach yelling at like an 8-year-old. So it's not just a college problem. It's a cultural problem. And I think, in America right now, if Karl Marx was writing, he might say that sport is the opiate of the people. And I think that we have to guard against that. So in our current model that's in place at most places, the vast majority of healthcare is done on a team by team basis by providers, again, who are paid and supervised by the athletic department. And it's a sports-based care and coverage model. And quite frankly, prestige and revenue of the sports drives the number of healthcare providers in many cases that the sport gets. A history of winning and success, and we see this in ads. We see ads that are looking for a men's basketball athletic trainer or a softball athletic trainer or a women's soccer athletic trainer, and those are not descriptions or modifiers of healthcare providers. And our institutions, and I'll give an example here of basketball. Men's basketball, that athletic trainer, when basketball season starts, is pretty much with that team all the time. They go to lift, they go up to practice, they come down. Now, this is usually one of the more senior. It's a very coveted job. It's one of the more senior jobs in the athletic department. You're seeing 12 to 15 players. If you have a scout team, you're seeing 30 players. And you're going up and sitting at practice, and maybe you're going and sitting in the weight room. Very little happens at basketball practice that you need a very experienced healthcare provider sitting watching practice. Most of the big time sports basketball programs now have an athletic training room just adjacent to the facility, and that healthcare provider could be seeing another student athlete from, say, the track team that has an athletic trainer who does track and field and baseball, and they don't have enough time to see all the patients they have in their panel. So I think we have to change our ideas around coverage, and I'll get to some ideas and some things we implemented where I was, and actually that's the next slide. What if care and coverage was based on the health profiles of the individual team? What if we have more athletic trainers and more healthcare slots available for those teams that had the highest injury rate, the number of individual participants, or the characteristics of the individual patients? So if you have a patient who is very prone or has a health condition that makes them much more susceptible to injury or a bad outcome, then maybe that's the practice that we send somebody to watch. I don't know why 3 athletic trainers are at football practice when it's a walkthrough day and you're in street clothes. So I think that if we look at healthcare for our student athletes, we really should start to evaluate what's the most efficient way to deliver that healthcare. And I want to encourage folks to just stop me and ask questions, disagree with me. Should have said that right at the beginning. So any thoughts at this point?
I have a question.
Yep.
Are you saying that it would be more, I guess, of a consideration if you would have more athletic trainers with a team that anticipates more injuries and then fewer with those that may not, like golf as an example?
Exactly. There's a conference in the country that has a rule that a full-time athletic trainer, so you can't hire a part-time person, you can't hire somebody to travel with women's volleyball. Now, when I heard about this, my first question was, did they take the net away from women's volleyball? So I can see why you might have a rule that says you have to send an athletic trainer with a football team or a lacrosse team or ice hockey team. Those are all men's or women's. Those are all really dangerous sports, high injury rates. But I think we have to make decisions external of the. We need to make them on data, on the characteristics of the people who are on the team, and the injury rate and the relative injury rate of our team versus the other teams being left uncovered or untreated.
Thank you.
Did that answer your question?
Yes, it did. Thank you.
Yeah.
Yeah.
So,
Yeah,
anybody else?
Yeah, go ahead.
My question, is the NFL has somebody in the stands, observing hard, difficult contacts.
Yep.
Make sure that there's not a concussion, or that at
Yep.
least they go through a concussion protocol. Is there
Mhm.
anything in the NCAA that does something similar?
Absolutely. So there's spotters at the NCAA. There's spotters at the NCAA. I'm familiar with Division I. I don't know if it's all the way down to Division III. I haven't worked at Division III in a ton of years, and it's just not something I know off the top of my head, but I can find out for you.
Now, how about other sports like soccer, where there's a lot of head contact? Do they have
Yeah.
similar?
They do not have independent spotters at any sport that I'm aware of other than football.
Thank you.
Mark, I want to make a comment.
Yep.
I was fortunate to travel with a basketball team one year.
Yeah.
What they had the trainer doing, it was a lot of other miscellaneous jobs.
Yep.
too. My concern was, what if the stress that was put on him is going to limit him from giving the proper care to all of these athletes? And what if he get injured? And then
Right.
you're relying on him. So, and then they're not paid the greatest. So I just feel like a lot of those things are other issues that a lot of these trainers.
Right. Absolutely. And, I think when you move the athletic trainers out of the athletic department, and I'm going to talk about a model, one model, then you don't have the healthcare provider cleaning the coolers.
Yes.
The manager can clean the coolers.
But lifting the bag, taking the bags off the
bags off the bus,
or
off the plane. Yeah, that's not a healthcare activity. And I think that's where we grew up as a profession. We're folks that want to take care of people. We're folks that want to nurture people. And quite frankly, that was okay. And I was a Division I basketball player, a basketball athletic trainer way back. And we all helped. Everybody helped. The players helped get the bags and equipment off. The manager, the athletic trainer, the head coach, everybody helped. Mark,
I'm gonna say something that's gonna make you laugh. They wouldn't let the athletes take the bag off because they were scared they may hurt themselves.
So
and I'm like,
Water polo, we did.
I'm serious.
We must be stronger than y'all, because
it is. If you got a basketball player who hurts himself taking the bag off the bus, you need to recruit a little different. I'm pretty sure. But so I think this is our traditional kind of athletic trainer mindset that we're talking about. And I think that some of us are stuck in that mindset, and some of us just realize that is the power dynamic within the athletic department, and that if you don't keep that coach happy, you're going to be in either your boss's office or the associate AD's office or somebody's office, telling you what you need to be doing and to adjust your attitude. Now, as a licensed healthcare provider, so and here was another thing I want to talk about and introduce to you is there's a breadth of knowledge in that an athletic trainer has to have, and that is wide. Everything from primary care, flus, colds, skin conditions, appendicitis, concussions, orthopedic injuries, behavioral medicine. We are seeing more and more behavioral medicine challenges. There are universities where at the University of Alabama, they have a great program where an athletic trainer, a lot of what she does, correct me if I'm wrong, Jerry, is coordinate care for folks who have behavioral medicine challenges and educate other providers about how to spot those challenges. Maybe
No,
Jerry.
you're exactly right, Mark.
Right.
Yes.
And I actually stole that from those folks when we started up at BU, and I'll talk a little bit more about that right now, which is we're getting into this idea of expertise, and you can't be the best person on for that patient for every problem they have. You know, this is why physicians practice in groups, and they don't practice by themselves anymore because medicine's become too complicated. And even in a primary care practice, you have primary care physicians who specialize in sports medicine or orthopedics. You have some who specialize in OBGYN. You have others who specialize in addiction. So you have, and they still see the normal run of the day conditions that patients come in with, and they still see their patients who their primary care provider for, but it's their job to get that patient, if they can't help them, to somebody who can. And when we look at athletic training, we're talking about orthopedics, emergency medicine, rehabilitation, primary care, diagnostics, in addition to behavioral medicine. There is just so much content that we're teaching our athletic trainers in our professional programs. Greg and Jerry both teach in those programs, and they can tell you that the educational competencies have expanded to the point where our educational requirements are in line with other mid-level providers, and that's nurse practitioners and physician assistants. And all education is at the master's level now. So there are no more students who are entering as a baccalaureate athletic training student.
Terry's got a question.
So it's Randy Lee from the University of Houston.
I'm sorry, Randy.
I'm wondering, do you have preferred models for how to deal with these high impact sports, how to deal with concussions? Like, is there, in addition to a trainer with specialty in that arena, with a neurosurgeon or something like that, do you have preferred models that you could suggest that?
Yeah, I think certainly getting baselines and screening is absolutely necessary. In my opinion, I think an athletic trainer who focuses on concussion evaluation, but more importantly, concussion rehabilitation. And I think that having some member or members of your staff, depending on how many collision sports you have, really necessitates that somebody on the staff sees every head trauma that comes through to standardize the care. I think the other thing is a sports medicine physician with a CAQ So a certificate of advanced qualification in sports medicine is absolutely necessary as a referral and check before any of those folks return to participation. Whether a neurologist needs to be involved or not, I think that's up to the physician and the athletic trainer who are treating that patient. But it's not, concussions aren't one of those conditions that every athletic trainer on the staff can treat. In my view, I mean that, be totally responsible for their care. They certainly can do some of the rehabilitation exercises. They certainly can do some of the monitoring, but the decision making about return to play should be done by someone with advanced training as an athletic trainer in that area, through continuing education, through experience, through working with a team physician who again has a advanced qualification.
So the first step is to have a baseline measurement in milligrams.
Yes.
Then have people with expertise.
Then have people with expertise, and I think tennis players get concussions, but the person who primarily at a big Division I school where one person takes care of tennis, they don't see them very often. If I have something wrong with me, I want a doctor who sees a bunch of it. So I go to a primary care physician who sees a bunch of old fat men, and then she's pretty good. She knows what's going on.
Is it true now that all institutions do a pre-assessment on all their athletes?
Yeah.
I mean, I know there's web-based. Okay, good.
They do.
So everybody's got pre-assessment.
That's part of the concussion requirements by the NCAA. Okay, so again, I think this speaks to, we really need to refocus our idea from this coverage of teams or patient panels that and focus it on, I'll talk about it in a minute, but I'm going to introduce it here. Really, all student athletes need to have a primary healthcare provider who they're going to touch base with, an athletic trainer who coordinates their care, who they come to when they have something wrong with them, who helps them get oriented to the campus, to the healthcare system, who takes care of them, who's their main contact. But it's that person's job to get them to the best person at the university, whether that be somebody in behavioral medicine, whether that be somebody in the surgeon's office, whether that be another athletic trainer on staff who just is more well versed in what it is they do, what condition they have. So then, just some rhetorical questions. Why would an athletic director be a suitable supervisor for a healthcare professional? So, and this is what you get when you have somebody who doesn't know the field to be evaluating you. It would be like if you're a physics professor and the chair of the English department is evaluating you for tenure. It's not going to probably be a great learning and growing experience for you. So, and we have some historical and cultural problems. Okay, we're doing okay on time, right?
Go ahead.
So in the past, new athletic trainers would take jobs for $24,000 a year and some free gear, or when we were at the bachelor's level, grad assistants. Most of the folks who were delivering healthcare, sometimes at Boston University, when in 2008 we had 9 graduate assistants. So, and I'm sure Alabama had a bunch. I know Tulsa had some because sent some of ours out there. I actually think, but way back we had somebody at Alabama from BU, an undergrad. But this environment has changed. This is no longer the case. And what we hear from athletic directors and athletic departments are, well, we just can't hire athletic trainers because there's a shortage. And this was actually something that our profession, the leaders in our profession, the Board of Certification, which has the licensing exam, or the certification exam, which leads to licensure in every state but California. The Katie, which I work for now, and Greg was president of, and really got me involved with the Katie a bunch. Who accredits educational programs, and then our professional organization, the NATA. They met with the NCAA leadership, some members, athletic directors, some members of the executive council, and the associate director this summer, and explained to them there are more certified athletic trainers right now in the country than there have ever been. There's not an athletic training shortage. There is a shortage of students who graduate from a master's degree who are willing to take a job for $24,000. That's a pretty stark shortage. And not only that, the military, and I'm just on the phone with two of the folks who run the Army's H2F program, Holistic Health and Fitness. Yesterday, they're going to hire 600 athletic trainers in the next 6 years. Physician practice, there's a huge society. Athletic trainers are working in physician practice, from primary care physicians to neurosurgeons, as mid-level providers. And in an orthopedic surgeon's office, they're gathering grafts, they're preparing the grafts, they're closing the incision, they're doing those type things. We have folks working in industry. Boeing hires a ton of athletic trainers. So does UPS, and has for years. Any questions? No. There are athletic trainers who now, like the traveling nurses, traveling athletic trainers. There's some folks who are making upwards of $70,000 and $80,000 a year, not even working the full part of the year, just going and taking a 3-month gig for a family leave situation, or filling in when somebody leaves abruptly. And then the entertainment industry, Circus Soleil hires. At one point, when Cirque was, before they constricted, they had almost 100 athletic trainers that were working for them with really good jobs. So I'm going to talk about our model at Boston University next and what we did. So I'm going to stop right now. Any questions about this first part?
I have a question.
Yeah.
I'm just curious. You mentioned Boeing.
Yep.
What type of, I guess, work will an athletic trainer do with Boeing?
So yeah, so the folks who are on the line who are putting together the planes, when they get injured and they have to come off the line, that slows production. So they do evaluation of those injuries, treatment, rehabilitation. They also do risk mitigation. They look at, athletic trainers are trained in evaluating ergonomics. So they look at ergonomics, they show them how to lift, they do patient education. So they do all those things.
Thank you.
Mm-hmm. So I'd been on the faculty at BU, and this is my cup of coffee story for South Carolina. I went down to South Carolina for a year and actually made some of my best friends I have, and taught there for a year. And then Boston, and I had been a faculty member, and I'd also been a clinician at BU and been the acting head athletic trainer there for a year. And they called me and said, would you want to come back? We are going to take all of athletic training out of, we had athletic trainers kind of all over the campus reporting to different folks, and they wanted to centralize that. And so I said, and they couldn't keep staff. They just couldn't keep staff. One was they weren't paying enough, either in club sports or in recreation or in varsity athletics. And the working conditions just weren't good. They were working 70, 80 hours a week, traveling. There weren't enough of them. So we started to look at disrupting that model. And at BU here, we have the Department of Athletics, and this is what what it was when I went back. And actually the gray over here, we didn't take the Department of Military Sciences in until about 6 years in. And I was speaking with one of the, in an establishment, I was sitting next to a guy who was a colonel, Air Force colonel. We were talking, and he ran the military science department. BU has a very large one, all the branches. He said, you know, I'm responsible for all the branches. We have about, with crosstowns, we have about 350 people. And last year, 24% of them, we lost them because they couldn't pass the physical exam because they were hurt or some problem. I said, well, we can do something about that. And the next year, we started with an athletic trainer, got some money, hired an athletic trainer, a graduate assistant at that time. And the next year, they lost one person out of 300. When you think about the tuition revenue, because when you wash out of ROTC, especially at a school like Boston University that costs what it costs, or Tulsa, a school that costs what it costs, those students go someplace else. So we brought them on board. So any questions about that? So there was really fragmented care here. Everybody had their own budget, everybody had their own policies, everybody had their own equipment. Nobody even shared coolers. No varsity athlete ever walked into the clinic that the club sport and recreational athletes used. No club sport would be allowed into the varsity athletic training room. It was just really unsustainable. So the dean of the School of Health Sciences and the chair of the Department of Family Medicine got the ear of the executive vice president and started talking about a different model. And this was at that time, they had just hired a new director of health services who was interested in sports medicine. He was on board. So they set up a hierarchy that looks like this. So we were part of student health services. All athletic trainers on campus worked under the student health services environment. And that's what's happening today. Student health went through a bit of a transition, and for a while, the director of student health and myself reported directly to an executive vice president. But for the majority of the time, we've been treated as one unit. So one of the first things we did was use the same electronic medical health record. And that's the same medical health record for behavioral medicine, for student health, and for all those folks who participate in sports or ROTC on our campus. And all providers have access to all of those records, with the exception of the behavioral medicine records, and only athletic trainers whose area of specialty is behavioral medicine have access to the behavioral medicine records. But again, they're licensed providers. Just kind of going through.
Greg, is that a structure similar to what you have?
We're heading that way. It's not without growing pains.
Yeah. It's not easy. There's a lot of sleepless nights and negotiation, but it's worth it in the end.
So Mark, one of the questions that came up in here, and it comes up every time we talk about this model, people say, and administrators say, well, how much money is it going to save?
I'm gonna talk to you about that right now.
And I go ahead. Yeah.
So let me one or two more slides, and then I'll talk about the savings. Well, let me just talk about the savings now. So we went at Boston University from, first of all, the money we saved in ROTC alone in lost tuition dollars is very significant. Second of all, I think students who are able to participate in, especially on the club sports side, who are able to participate in club sports and don't wash out because they get good medical care, they're pretty sticky. They stay and go on, and it's one of the things we were just beginning to do when I left, is look at our patients and compare them to folks who weren't our patients and see how sticky they were, compared to before and after. So I know that I worked at Division 3 for a little while, and that was really the big push there for good health care for them, because even if they dropped off the team, if we kept taking care of them and they could still be around, they were more sticky. So and then what happened a year before I left, so that would have been 2021, is we decided to not go with the gap insurance any longer, because for the 4 years before that, we hadn't used the NCAA gap insurance between the insurance you buy, athletic insurance you buy, that carries you from the students, either student insurance or their family's insurance, to when the NCAA takes over for big time expenses, when the NCAA insurance kicks in. So we were paying a premium that was higher than what we were drawing out of the best plan we could get on the club sport side and the best plan we could get on the athletic training side. So and I don't know the acronym, but there's an association that governs club sports, and they help with that insurance, just like the NCAA help getting group insurance. So those are two big savings, Greg. And then turnover was another savings. And then I think we're going to talk here about, you have one cost center, so you really can get all of that. You can figure out how much it's really costing you to deliver the healthcare. You don't have athletic trainers all over campus and costs all over campus, and figuring out what's leaking out and what's really wasn't an athletic injury, but they claimed it was an athletic injury, and now you're taking care of them. So certainly insurance processing is a huge help when you get out of athletics and you use the insurance processing person in student health services, who's actually, you take that off the athletic trainers or the person in the business office, and they go to somebody who's actually trained to process insurance claims. People who are trained to do stuff do it way, way better than people who are kind of doing it as a sideline. So we had access to general counsel, and here again, the cost reduction. You're buying supplies not out of different budgets from different vendors. You're able to leverage all that into one vendor, and then you're leveraging that vendor through student health services as well. So at a major university, there's a lot of savings and reduction of costs to have one cost center. And then you're also having a privileging and credentialing system, which all medical professionals do, except for, to my knowledge, there's no athletic training group, no university whose athletic trainers are privileged and credentialed by the university or by that student health services. So that's another benefit in terms of risk mitigation. And again, patient privacy, healthcare literacy, and I want to talk about that a little bit, and that's my next slide. And then just standard medical rights. So in the athletic department, you really don't have a right. You don't have a right to ask for a second opinion or to change clinicians. Our student athletes at Boston University, all three groups, get a notice when they come to campus. You have a right to ask for a second opinion anytime. If you don't want the clinician you have, you can change clinicians. All you have to do is ask. And then I think that we, as healthcare professionals and as universities, we have a a responsibility to educate our students to navigate the healthcare system. And quite frankly, I was really tired and I handled healthcare claims for years for students. I made appointments for them. I drove them to appointments. These are all things that come graduation, they're going to have to navigate on their own. And so we help them. We have insurance folks who help them. They can stop by the athletic training clinic and get help anytime they want in terms of helping them getting their papers together, doing a little bit of education. Now, we don't do it every time, but we start with the freshmen and work through. We teach them that really the person who knows their schedule best is them. And if they're on the phone with a scheduler from the doctor's office, and we sit with them the first couple times, but they can make that appointment, and then they can get to the appointment on their own. We'll speak with the provider afterwards. We do have a policy that if the clinicians feels like it would be beneficial for them to be in the appointment, then we go with that patient, whether they're a club sport again or a varsity athlete or the best athlete, the star player on the campus, the Hobie Baker winner that BU just had. My folks from Northeastern are gone. So, so I think that this is the real world, and it's the world they're going to live in. So I think we do a good job of that, and folks who are in health services do a good job of that for our whole student body. This isn't something that we thought up in athletic training. This was being done at student health, was being done purposely, and we just rolled our student population in there. I've talked about specializing and developing advanced care practitioners, and I think this is the common health record, and being able to really search a good EMR about what kind of cases you're seeing and what you're seeing really can let you know what your patients are experiencing. And we know the literature says that of extremely active college athletes, females have about a 45% chance of having urinary incontinence. And males about 14. No, I'm sorry. That study was a European. No, that's the U.S. study. And then there was a European study of female elite athletes in Europe, and 76% had urinary incontinence. So when we started seeing this come through in our electronic medical record, we weren't seeing as many patients in our clinic, but they were being seen in student health, and it got flagged as a population that had a higher incident than the regular population. We took one of our athletic trainers who was interested in this area, got her advanced level training. She started training with the nurse practitioner in student health who saw most of these cases. And she eventually when I was there, had her own clinic in student health to see physically active students, whether they were in our patient population or the general population, who were having urinary incontinence challenges, to do focused rehab on them and education. So another challenge we had when we started, and the pay challenge, really, when you get out of what happened for us when we became part of the student health services, we went into their HR rep. So we came out of the athletics HR rep, who was dealing with coaches and endorsement deals and contracts of those type, and started dealing with the folks who was hiring the nurses, the nurse practitioners, the physical therapists on campus, those folks, and that really helped us. I will say that this was the job performance factors when I got there, and with the help of one of the assistant directors who had been the head athletic trainer for club sports, Jennifer Chadburn, did a bunch of research and got to there's a 360 exam for a 360 evaluation platform for physicians and residents and fellows, and we adapted that to to athletic training. And this really helped us go a long way toward at HR toward toward talking with them about our compensation. So athletic trainers' jobs are those folks who are with men's basketball sometimes are working, and I did it 70, 80 hours a week. You're traveling, you're at every event, you're going up at shoot around, you're carrying the coolers, you're unloading the plane, all that type stuff. But when you have a coordinated care approach and you don't do those type activities, you're able to staff in a different way. That means the patient still has an athletic trainer who's their athletic trainer, who reads their chart and knows everything that's going on with them and sees them primarily for what they need. But other people can read their chart and do their treatment if their appointment time doesn't fit with their primary athletic trainer. So we started collecting data right from the beginning, and first we were just collecting the amount of hours in a day and and how many days we traveled, and we found that didn't work very well because some people were working 40, 50 hours a week, but they were just crushed, and it was really they were either working really late at night or early in the morning was the big challenge, because they'd come in early and 4 days a week and leave at 4 or 5 o'clock, and they couldn't really, by the time they got their children, they couldn't get to the barber or the beauty shop or to the bank. So we started tracking early morning hours and late hours, and then also tracking travel. And here's some FY20 data. This top person is me. I was traveling a bunch for the Katie at that time, and doing site visits and traveling for the university with admissions. Some of the other folks down here were folks who were heavy into their doing continuing education to develop their specialty. So and then when we went to obviously FY21, who had some COVID time in there, we didn't have as much travel, but we're still looking at, for a healthcare provider, these are pretty good hours totals. And I think Jerry and Greg can tell you that anybody in the country would exchange these hours for the hours they're working, I believe. The sane people anyway.
Yep.
So, and here's what it looks like over time. And as soon as we start getting up here, then we ask for more staff. All these metrics allow us to grow the staff, and I have some data on that coming up real soon. So, and then my colleagues in sports medicine, and some of your colleagues, when you go back, will say, well, they must never, ever see anybody. They must be closed all the time, and their clinics must look like this. That's not the case, but it's also not the case that every clinician is on call for their team every night. That basketball athletic trainer, he's on call for that basketball team all the time. And some of the calls, when you're working with a Division I basketball team that are on the fringe of healthcare, that you get really late on a August Friday night, are interesting. But what we have is a clinician on call for every day. It's right on the Student Health Services website. You can go there as an athlete on any of these folks and find out who the clinician on call is. Their number is also on our answering service. And then we have a senior staff member on call as well. Every night, and there were 3 senior staff members who had expertise in behavioral medicine, so they rotated there as well. So but again, folks, they were closed. And in 19, right before the pandemic, there was somebody treated in the clinic 361 days, or 99% of the time. And we treated way more people than we treated when we had a walk-in only not a patient panel coordinated care approach, but here's some of the patient numbers in terms of patient contacts. And this is a significant contact. This isn't giving somebody an aspirin or helping them, tape on their shin guards. This is a treatment or an intervention. So you can
let's stop and let this sink in, Mark, on
yeah.
how much more healthcare you were able to provide with your staff using this model. Look at the numbers. It just blows my mind. We talk about making a better system to take care of our athletes. They're the numbers. There it is.
Yeah, and I mean, Greg, it was just that old story of the baseball or the softball player walks into the clinic and says and Jim is the athletic trainer for softball, and she says, "Is Jim here?" And there's 3 people sitting in the office, right? And they say, "No, Jim's not here. He went up to lunch. He'll probably be back in an hour." And that patient walks out the door and comes back in an hour. Now, that doesn't work in a healthcare model. That patient gets seen by somebody who's there sitting in the office. And that does 2 things. It saves the student time. They feel respected and cared for. They're not having to run all over campus. And I get a built-in second opinion with a note. So they got to read the note and figure out whether they agree with what Jim's been writing, and those 2 can have a conversation. I don't need to get involved. But you have an increase in patient, not only numbers of patient, but quality of care. And I can't emphasize that enough. When more providers, when you get a patient to the provider who's the best person to treat them, and when your group is willing to take on patients who aren't in their panel, when they come in seeking help, you get a lot of things caught right when it happens. And we all know that in our athletic training rooms, sometimes we see emergent stuff. And we've had patients who've come in with something that's emergent, and they've gone back to the locker room because their athletic trainer wasn't there. And that's just the wrong culture. So we talk a little bit about finances next. So when we first started this, went down to, as we were starting, human resources was really not feeling us at all, and was a little skeptical of this whole thing, but it had come down on high, so it was going to happen. So they didn't know we were healthcare professionals. In fact, they didn't even know we had licenses. They didn't know we were licensed by the same board as physical therapists and occupational therapists. So that was a challenge. So once we figured all that out, they said, "Oh, well, this isn't right." So we left and came back, and they had said, "Well, we reevaluated this, and we're going to give these people a raise. But we're not going to give any of these assistant athletic trainers a raise, because you can't. I mean, if they're just assisting athletic trainers, they don't get a raise." So this is another thing that on your campus, this coaching vernacular, you don't have assistant doctors. It's just, in fact, physicians assistants are now physician. They just changed their name to physician. It's not extenders. Just in associates. Right. Thank you. Physician associates changed it in December, I believe. So this was really helpful. And then they said, "Okay, we're going to do equity, pay equity evaluation. We're going to do one at all of the our like schools." And I was really happy. The external folks, I knew we'd be good with that. And then we're going to do some internal equity as well. And I knew we would be struggling because they wouldn't want to give us a bunch more money. But we worked through all that with the assistant. We did had our admin assistant pull all like universities, BU size, Division I with the same academic profile and same size, and look at athletic trainer salaries. And we kept that database for, I don't know if they're still keeping it, but we kept that database up till I left. But I'll tell you what has happened. This is what happened since 2008. So we went from 13 full-time athletic trainers to on campus. No, we went from 9 full-time. No, we went from 13 to 20, whatever that is, 21 full-time athletic trainers and 3 full-time residents. The residents made in 2022 $50,000 a year. I can tell you, based on the database that I look at, that I had in 2022, there are a lot of athletic trainers at a lot of Division I schools that are the athletic trainer for swimming or the athletic trainer for field hockey or softball who aren't making $50,000. And the university, yes.
Mark, you might want to explain what an AT resident might be.
Okay. Yeah. So an AT resident is so that the athletic trainers started accredited residency programs. They accredited their first residency program in 2012. PT has accredited residencies. It's an academic and clinical, just like physicians, academic and clinical course of study. There are now 15. Well, when Jerry votes next week, there'll be 15 accredited residency programs across the country. We got another one coming through, Jerry. These are folks who are specialists. In orthopedics right now, we have residencies in orthopedics, rehabilitation, and pediatrics. Is that good enough, Jerry?
Perfect.
And we do have a specialty certification exam for orthopedics. So, and the other exams will be developed as we get more residency trained. So, what are some tangible things, just to give you an idea of how much, if you're a faculty rep, these are things that you may just see if you're doing it at your place. And you are the faculty rep, so you might just see. Again, this common medical record is just key, so that you have all the information and you don't have this problem of the student athlete going to student health and hearing one thing and coming to athletic training and hearing another. And you also have expertise for all your students in student health. So when times are slow in the summer, athletic trainers go down and do clinics in student health. Our orthopedic residents do clinics in student health. So they actually get to see students who aren't on a varsity team or a club sport team or ROTC. So we're integrated into that whole system. You have to measure outcomes, patient-rated outcomes and clinician-rated outcomes. Medicine is terrible at this. Athletic trainers are very bad at it. So, and I got 3 minutes. So we'll work on through. Critical reviews are anytime there's an incident on campus. This is actually something that student health adapted from us. So anytime they have a transport or anything, they go through a full review of it. Again, we do built-in chart reviews and chart reviews. I think I'm going to just go on through the rest of this. We do M&M conferences. I was a faculty in residence at BU. So I didn't live in this dormitory, but I lived in a dormitory like it for about 17 years and absolutely loved it. I have some slides here at the end about talking about this process and how to become operational. And I'll send a PDF of the slides into whoever you want me to. And I'll take 2 minutes of questions.
Kelly would be the person to send it to.
If whoever the person is will just send me an email, that would be fantastic.
Okay.
Mark@katie.net.
Yeah, you bet.
Okay, great.
So Mark, one of the things that we had talked about earlier.
Yeah.
Was if you pay a coach $8 million
Right.
You give them $8 million of decision-making authority.
Mm-hmm.
So there have been situations where athletic trainers have been fired because they made a healthcare decision that was contrary to what a coach wanted to see happen.
Yeah. So I will tell you that we had a few of those rubs. You know, I mean, there's no racing without rubbing, right? But you know, we report up through the general counsel, through student health and the healthcare general counsel, and it didn't take but like a minute to get that solved. It happened in the first year and a half, and it hasn't happened since.
Thank you.
And we have some coaches who are, you know, our hockey team just finished fourth, and you know, we're not up there in the Tulsa world, but
Yes. Other questions for Mark? Anything? I think the point we were hoping to make, Mark, with you was that with this content is that the best healthcare delivery system for our athletes is going to be where we break tradition. We're not part of the athletic department anymore.
right.
We're working for physicians or in this patient-centered model.
It's common, and again, Iowa, Vanderbilt, Northwestern. And I don't do consulting. I don't get paid to do consulting. Any of you folks who are interested, on the top slide is my contact information. Please either call my cell phone or shoot me an email.
Mark, thank you. We appreciate your
Hey.
time.
Thanks so much, Greg, and all as we say in North Carolina, all y'all. Appreciate you.
I learned a new term. There's no raisin without the rubbin.
Racing. It's a
Raisin.
stock car. Yeah.
Oh, okay. I was like, I was
Now.
trying